Right, thank you everybody for joining us today. This is our first surgical webinar series. Those of you who attended the previous series earlier on this year, will be run in a very similar format. Those of you that didn't attend earlier, if you'd like links to the videos of our previous webinar, please feel free to email us and we will provide that for you. SafMed, as you probably well know, has been around for over 30 years now, and SafMed also is well known for supplying as well as for knowledge and education in the area of CSSD. As you know, we have a variety of products, and that gains us a lot of experience in that arena. Not many people are aware of our expertise in the surgical realm, specifically, of course, around the operating room. If you have a look on the left over there, we refer to some of the products that are in our preview in terms of surgical. So you may ask yourself, why a surgical webinar series? And we think that it's quite important to share knowledge. As you know, we've been doing that for a number of years. And a lot of you are aware of the fact that my job description clearly states that I need to remain abreast with what's happening by reviewing a variety of journals. And when I'm reviewing the journals, I come across so many various presentations. I come across an incredible amount of information that's also theatre focused. And because I am theatre trained, it is really interesting information, and I think it's time we share that. Along with that, we've developed additional resources in our surgical field. Nanette Warburton has joined us from procurement. Nanette is also an experienced unit manager in the operating room, has worked in local conditions and overseas as well, and brings to our party a whole series of resources in education. Then, of course, is Justin, our marketing manager, and Justin is really quite innovative. He's IT savvy, he understands digital platforms, and because of this, he's managed to orchestrate that we are now able to do these kind of webinars and this type of training and presentation. So thank you, Justin, for bringing that to SafMed. Over and above that, because we do sell a range of surgical equipment, it gives us access to information. All the manufacturers are really aware of what is required when it comes to manufacturing and selling and promoting and being able to use all of the surgical equipment. And that gives us a whole series of information, again, that we think we can share, and knowledge is power. Similarly to the circle that we would follow when we are cleaning or decontaminating an instrument, we have a journey. A patient has a surgical journey to follow. And I've highlighted some of the steps in that journey, and we're going to work through that journey in this series of webinars. Of course, we're going to begin by preparing for the surgery. We get the operating theatre prepared. We clean the operating theatre. We bring in all the equipment that's required. We send for the patient. The patient arrives. Hopefully we have the right patient. We bring the patient into the operating room. We transfer them safely onto the operating table, and we at some point need to put the patient to sleep. Once the patient is asleep, we will need to then position them for the surgical procedure. Once they are safely in position, we will prep and drape the patient as normal. Then we bring into the field all the equipment that's required. Eventually we perform the surgery, the patient hopefully does well, and at the end of the procedure the patient moves along to the recovery area. So in this series we will focus on various areas of the patient's surgical journey. We will host a total of 5 webinars in this surgical series. This first webinar will focus on preparing for the surgery and developing bad habits and the consequences of those bad habits. Webinar number 2 on the 22nd of October, Briette du Toit has kindly agreed to present on that day, and she'll focus on when and how and what we need to monitor in our operating room environment, so from an IPC perspective to make sure that our environment is good and safe for our patients. The next 3 webinars will be on the 29th of October, the 5th of November, and the 12th of November. And those 3 webinars, we will continue along our journey of the patient surgical journey, and we'll focus a lot on patient safety. Things like patient positioning, but not only patient positioning from the patient's perspective, but patient positioning in terms of staff injuries. Interesting topics like retained surgical items, specimen errors, sharps management. Swan Morton have kindly shared quite a bit of information with us that we will use to present with, really good information around managing sharps correctly. Fire safety, a concept I don't know if any of you have ever experienced. I've had at least 3 fires, patients catching fire on the operating table, so a subject close to my heart. Streamlining instruments in instrument trays and the value add of that and the importance of theatre's involvement in that. Managing surgical tables, surgical timeout, understanding surgical lights, and what do you need to look for when you're buying or purchasing or demoing a surgical light, where's the value add. Managing your surgical tables, that's a concept that I think is becoming closer and dearer to our hearts all of the time. We all are working under restricted budgets. We're all in times of constraint, and we need to find ways to make sure that our equipment can last for as long as possible, and we need to manage it, look after it, so that we don't need to spend our days having to repair these items. In today's session, Preparing for Surgery and Developing Bad Habits, we'll focus on operating lights and how clean are they? Are they a source of contamination in your theatre? The misuse of scrub basins, traffic, door openings in the operating room, risks associated with noise and distractions in the operating room, and we'll end off with a mental health component, bullying in the operating room. Preparing for surgery, let us begin there. The World Health Organization's guidelines to prevent surgical site infections are quite clear. There are a number of steps we need to follow, and one of the most important things, of course, is cleaning and sterilizing our surgical instruments and devices that we're going to use during the surgical procedure. But please don't forget about the importance of cleaning and preparing the operating room environment. I'm sure Briette will refer to this in a bit more detail. In the mornings, of course, we damp dust our theatres. I hope we still do that. Between cases, we need to clean, and that cleaning will include cleaning the theatre lights, mopping the floor, cleaning the bed, and hopefully at the end of the list, we orchestrate a push-out. As a student nurse, push-out was my favourite time of the day because I could splash around lots of water and finally get rid of the stress of the day. I should imagine that if you're a patient and you were wheeled into the operating room, there can be nothing worse than lying on the table, looking up at blood splatter or betadine solution or something of the sort splashed across the operating light. I should imagine that that would be quite daunting. But are our surgical lights clean? A very good question. This paper, published in the American Journal of Infection Control in 2013, looked at whether or not the lights were cleaned in 5 operating rooms. The lights were tested for bacterial growth and cultured, and amazingly, or perhaps not so amazingly, indeed, a variety of microorganisms were cultured off the lights themselves. Even worse was the Staphylococcus epidermis was multi-drug resistant. Bad habits can definitely develop and become sources of contamination. This paper was published in the American Journal of Infection Control in 2020, and it looked at sources of contamination specifically around forced air patient warming devices and around the operating room light and movement over the sterile field. What happened was they used this fluorescent particle powder and simulated patient draping, and turned on the forced air patient warming device prior to draping, and then tested it post-draping to see what the effect was, and then also created a series of movements with operating room lights over the sterile field. They could conclude that both forced air warming devices and operating light movements are a potential source for contamination or contaminating the sterile field and then indeed the wound. As a result, they have the following recommendations, and they are really nice recommendations. I'm not sure how actionable it is, though. They recommend that we need to delay the activation of forced air warming devices until draping is completed. I think that's possible. I don't think that's too difficult to do. And I think it's also very important to bear in mind that we use the devices correctly according to the manufacturer's instructions. Of course, we sometimes cheat and just take the hose and nip it under a blanket and don't necessarily use all the attachments and accessories that are supplied with those kind of devices. They recommend applying the light handles away from the surgical field, but minimizing the light movement. Often our surgeons will set up the lights before they go scrub, so it may be a little bit more difficult to move it away and then put on the light handle. And of course, if you need to move it away to put on the light handle, then you're not minimizing the movement. But where it really does matter is avoiding mid-air collisions. And mid-air collisions, of course, are problematic for the light itself in terms of causing damage, but also mid-air collisions will then create a bit more fall or fallout and potentially contaminate the wound. Another important aspect about mid-air collisions is when you're buying a light, just think about the design and the ceiling height. Those are very important concepts to bear in mind. And not all lights have the same length of arms, and those arms will influence how the lights perform and whether things whether everything collides together. Apparently, my sound keeps cutting out a little bit. It may be an IT issue. Hopefully, you can hear me clearly now. So, operating lights are definitely a potential source of contamination. Another issue, of course, is the misuse of scrub basins. A lot of you will recognize the author, one of the authors, Professor Shaheen Mehta, of this particular paper, that looks at the challenges regarding the control of environmental sources of contamination in the healthcare setting in low and middle income countries. As clearly stated, the risk of acquiring a healthcare infection is 20 times higher in low and middle income countries. And there is reference in this paper to a section about the misuse of hand wash sinks and, of course, the misuse of scrub basins. Sinks that are used for cleaning instruments that are actually the same sink that's used for scrubbing your hands prior to surgery. Definitely an issue with me. Often we end up cleaning urology instruments and a variety of other devices in anterooms or in scrub rooms in places all over the theatre complex, which of course is not a good idea. And one of the other bugbears I have is we often find anaesthetic nurses will be cleaning laryngoscope blades, especially in scrub basins, possibly using the scrubbing brush that the surgeon has just used, and often making use of the red hand soap. Definitely an issue for me. It is something we honestly need to look at carefully. Another bad habit is traffic in the operating room. As a theatre matron, I once found a representative that had snuck into my theatre complex, not into the theatre that he was meant to be in, but another theatre because his sister was having surgery that morning, and he managed to wangle his way in. I was absolutely devastated. We end up with quite a few people in the operating room, way more than we need, and of course we also need to control the representatives in the operating room. It's important to reduce the traffic as much as possible. In this particular publication, a poster abstract presented, published in the American Journal of Infection Control this year, presented by infection prevention nurses. They developed an order tool to count the number of times the door was opened in the operating rooms. They looked at the reasons for opening the doors and then put some process improvements in place to try to reduce the reasons for the traffic. In their mind and in their circumstances, it made sense to put the fluid warmers and high use of medications in the operating room. That could be something you think is a good thing or something you may disagree that that's not necessarily good practice in your environment. A really good one was updating the physician's preference cards, so to make sure that we had everything we needed at the start of the operation, and of course educating staff and anaesthetists and vendors, the surgical reps. In this particular instance, they were able to reduce the average door openings from 6.27 per case to 4.26 per case. That number worries me tremendously because if we have a look at the other research around door openings, I'm surprised it's that low. A paper published in 2018 around traffic, again with total joint arthroplasty procedures. Again, the objective was to reduce the number of door openings, because we know that frequently opening the door disrupts and changes the dynamics of the airflow pattern and results in the quicker spread of airborne microorganisms. They looked at the door openings in 50 cases, and it ranged between 7 and 141 openings. That must have been a terrible procedure that you needed to open the door 141 times during one case. On average, the opening times were 33.5, as you can see. So to try and create awareness, they installed an automatic door opening counter device. It wasn't very effective because the average number of door openings just increased. Eventually, they decided to hold an educational seminar and managed to reduce the average openings to 27.7 times per case. Coming closer to home, we're looking at traffic flow and microbial air contamination in the operating rooms at a major teaching hospital in Ghana. I really would love to do this research in the South African setting. I honestly would love to know how we perform in comparison. They examined the door openings in 124 clean or clean contaminated elective procedures. In total, there were 54, an average of 54 door openings per case. 17% of them were deemed necessary when additional instrumentation was required. 6% of it, of course, was semi-necessary, is how they termed it, because that was lunch breaks and I guess bathroom breaks, which are required occasionally. And 77% was completely unnecessary and was all about social visits. Catching up on what happened yesterday on the weekend is really not a necessity during a surgical procedure, and it is something we really need to worry about now. We know there is a link between surgical site infections and traffic flow in the operating room. Another published paper in the British Journal of Nursing in 2019 talks to the fact that traffic flow and door movement into and out of the operating theatre are important modifiable risk factors associated with surgical site infections. And that, I think, is a very valid point, a modifiable risk factor. We can change our behavior, and we should be changing our behavior because this is a very important aspect. I'm sure Briette Tutoy will cover particle counts and the importance of doing our particle counts and the effect of door openings on particle counts next webinar. Another hazard of opening the door frequently has also been identified, and that is, of course, that it has been described that unnecessarily opening theatre doors and theatre traffic is a contributor to surgical error because of the interruption on the surgeon's concentration and an increase in noise levels within the theatre environment. I was reading an article yesterday that spoke about fatigue and decision fatigue and communication fatigue, which I think is something that happens quite frequently in our environment. Is there's so much information, there's so much discussion that it's very possible that we forget things or we miss things, and that has a terrible bearing on the patient. This article spoke about distractions in the operating room associated with anaesthetists, and there's an increase in the number of lawsuits that are being defended for anaesthetists because of the doctor potentially being distracted by the use of his personal electronic device. They cite an example of a 53-year-old patient who underwent surgery. And during the surgery, the patient's condition deteriorated and the patient subsequently died. And funny, the family sued. During the investigation and trying to understand what happened, various interviews were held, and it was realized that the anaesthetist was using his mobile device. So further investigations were performed, and they examined the surgeon's or the anaesthetist's phone logs and compared it to the logs on the monitors in the operating rooms. And it was clearly understood that the anaesthetist was, at the time of the patient crashing, was actually reading news feeds. And the doctor was then held liable for being distracted and for the patient's death. I do believe noise distraction is another bad habit in our operating rooms that can lead to potential sources of contamination and risk for our patients. In the article on the right-hand side, Noise in the Operating Room, that was in the Association of Operating Room Nurses Journal, reference to the top one, music in the operating room, is it a safety hazard? So I did a quick Google search and ended up in PubMed, and when I looked for that topic, to my amazement, another 5 articles popped up. So noise in the operating room, music in the operating room are all aspects that have been looked at and researched for a period of time and certainly appears to be of risk. The AORN article goes on to make the statement to say that music contributes to environmental stress, interferes with communication, decreases the ability of the staff to be able to perform tasks safely, and creates a threat to the safety for patients and, of course, personnel. I've worked in an operating room, or various operating rooms, where music was played, and some of them, for example, the plastic surgeon played gentle music, and it was quite relaxing and soothing and enhancing of the ambiance. And in other areas, of course, not. We had a gynecologist that used to play the most horrendous music really, really loud, even while the poor patient was awake and was going to have spinal anesthesia, and that could be incredibly disruptive. The AORN therefore has the following recommendations when it comes to managing noise and distraction. They suggest limiting non-essential conversations. That might be easy in some circumstances and difficult under others, because sometimes our doctors will chat to each other and chat about stuff that's perhaps not essential. Very important to limit the number of personnel in the operating room for a variety of reasons, of course, and limit the door openings for simple communications. Perhaps we can communicate using other methods. The equipment in the operating room, like vacuum systems and powered drills and metal instruments clanking and monitors beeping and alarming and blurting noise, we can't make that go away. That really does need to be there. I'm aware apparently of a device Nanette was teaching me of the other day that you can install in your operating room that uses a series of color indicating lights to tell you at what level the noise is. So you get an acceptable level. It goes orange if the noise is getting too high and red if the noise is really high. Thankfully it doesn't bleep or blurt, but at least it makes you aware of the level of the noise. And noise and distraction is definitely a safety hazard. Personal devices are problematic for a number of different reasons. It includes the amount of contamination of microorganism bioburden that ends up on our personal devices, whether it's the cell phone or the tablet that comes into the operating room. It does make sense to place them on vibrate or silent mode wherever possible, turn them off unless it's directly needed or relevant to the surgery, and where possible, of course, leave the device at a designated area outside of the operating room would be absolutely ideal. I do worry a little bit about the phone that is in the doctor's pocket that also went past the ICU department where all sorts of other bugs are. What are we doing with these devices? Can we manage them better? Moving on to the last section of today's presentation. And by the way, today's webinar, we've reduced our time frame down to around 40 minutes because we do realize your time is valuable and we don't want to take up too much of your time. Reviewing published papers on mental health, again, whilst going through the various articles and literature that I review monthly around the CCSD environment and, of course, the operating rooms, I come across the most amazing mental health-related published papers. In theatre as an environment is a high-stress environment, so, of course, as ICUs and many other areas, but I think it's important that we think a little bit about our mental health as well. I think in the next few months, the operating theatre environment is going to be quite stressful. We've had, of course, a period of lull with COVID, and I think once the patients have recovered and are brave enough to be coming back into the operating rooms and into our hospitals, there's a huge backlog of surgery that needs to be taken care of. Patients with all sorts of ailments that will need surgery, and I think there'll be a lot of stress on our environment very soon when we try to get through that backlog. And I think tempers will flare and we'll all be quite short with each other, something we really need to worry about. There's a nice, it calls itself the Operating Theatre Journal, but it's really an online magazine. It's not a peer-reviewed journal that anybody can access for free. If you just Google it, I'm sure you'll find it, Operating Theatre Journal. It's based in the UK, and in this month, in the September publication, they published the most amazing outcome of a survey that the AFPP, the equivalent of APSA or SATS in the UK, published an article that looked at a survey that was conducted around bullying in the perioperative workplace. 700 theatre practitioners took part in this survey. 96% of them had witnessed some form of bullying in the operating room. 89% of the respondents said that they had been a victim of bullying at some time. 50% of them said that they had been shouted at. If you did the survey in South Africa, we could probably say 100% of us have said that we've all been shouted at. In fact, I've been stabbed with a blade as well. 47% said they had witnessed their colleagues being sworn at. And I've certainly been sworn at a multitude of times. 49% of them said it wouldn't help to report it as it wouldn't make a difference. And 37% of them said they had decided not to report the bullying because the bully was more senior to them and they thought it would just make them more of a target for more bullying. So bullying in nursing as a whole is quite a tragic event, and we'll talk about that shortly in the next slide. But in the operating rooms, it can be quite a tricky scenario, sometimes perpetrated by the surgeon themselves, or sometimes by colleagues. And it really is not a nice thing to have to endure and to live through. I had a surgeon once that twisted a nurse's arm, a theatre nurse's arm, to the degree that she had to be booked off sick for a week because she had thankfully not broken a bone, but sustained quite an injury. Bullying is definitely a bad habit, and one that actually may become part of the organizational culture and at the end of the day is accepted and tolerated. This paper was published in 2020 in the International Journal of Nursing Studies, and it looked at the cross-cultural scope and review of bullying as a whole. Workplace bullying is a significant problem for nurses worldwide. It's a form of aggression at work directed at a person or a group of persons by a particular perpetrator or a group of perpetrators who have power over the targeted party. As I said, bullying sometimes becomes part of an organization's culture and is often accepted and tolerated. What I think is really important is the fact that the outcome of bullying is that it's going to decrease a nurse's job performance. And that decrease in job performance will definitely lead to an increase in medical errors and poor patient outcomes. This research's findings noted that the source of bullying seemed to vary depending on the culture and the country. The tendency in this research that they found was that in Middle East and Eastern Europe and Southern Asia, Latin America, the source of the bullying generally was a head nurse or a superior individual. The source of bullying in Latin Europe tend to be mainly from colleagues. And then the Anglo area, so that tended to refer to English-speaking countries. In that regard, bullying seems to come from both colleagues and superiors. Those being bullied resorted to various different types of coping strategies. One of them was a problem-focused coping strategy. In problem-focused coping strategies, that would be where the individual reported the bullying, tried to actually deal with the bullying, and actually laid claims or reported and tried to deal and manage with the bully. The emotion-focused coping strategies were the ones that involved avoidance and the ones that involved looking for emotional support from others. And I'm very sure, as you all know, in every theatre complex, somewhere along the line, there's a corner, an ante-room, or often down in CSSD, where people get together to have a little nyata about what happened and who did what to who. And I'm sure that's the area where we try to deal with our stress and manage our various bits of stress. So we all apply a different coping mechanism to try and manage this horrible habit that sometimes creeps into nursing, which is bullying. Hopefully something that we can get rid of in the future. So what have we covered today? We've looked at our operating lights. Are they a source of contamination? Are they actually as clean as we think they are? Are we cleaning our environment in our operating room as often as we should? Do we have an SOP? Do we have advice and suggestions from our infection control to make sure that we're looking after our operating theatres correctly? Are we cleaning the theatre table properly? Are we removing the mattress? Are we using the right kind of detergents or cleaning solutions to do that with? How do we use our scrub basins? Do we misuse them? Do we take shortcuts and clean some of our instruments on the side, in the corner, in the ante-room, soak them in something and reuse them? I've seen that happen even in orthopedics. We should not be misusing the scrub basins, and we certainly shouldn't be taking shortcuts. What's the traffic like in your operating room? Are the doors opened? Are the doors kept open? Is there a multitude of people in and out? How much noise is there? How many distractions are there in the operating room? Are we gathering and having social discussions that we really don't need to be having in the middle of the surgical procedure? What's our mental health like? Do we have a lot of bullying in the operating room? Is that something that we can overcome? Can we overcome these bad habits?